MOGAD, Myelin Oligodendrocyte Glycoprotein associated disease. This rare autoimmune condition of the central nervous system is associated with anti-MOG antibodies discovered in 2007. Didn't even exist when I started medical school, but now it's increasingly recognized. In this video, we'll talk about the symptoms, MRI findings, pathophysiology, epidemiology, and of course, treatment of MOGAD, and we'll look at 6 observational studies, citations below, and here are the timestamps if you want to skip ahead. The most common clinical manifestation of MOGAD is optic neuritis, or inflammation of the optic nerve, often causing pain and vision loss in one or both eyes. This is an MRI of someone with right optic neuritis. You're looking at axial images like this in the top image. This is the globe of the eye, and this is the optic nerve, which takes up the gadolinium contrast dye because it is inflamed. Often in MOGAD, there's longitudinally extensive optic neuritis occurring throughout the entire optic nerve, whereas in multiple sclerosis, it's usually a shorter segment. Also, the portion right behind the globe of the eye is often inflamed. This can lead to papilledema, or swelling in the back of the eye that can be seen with an ophthalmoscope by an optometrist, neurologist, or ophthalmologist. In the second image on the bottom, we're looking at coronal sections, essentially looking straight at the person, and you can see the right optic nerve is inflamed. Often in MOGAD, both eyes are involved simultaneously, as in these MRI scans. You can see both optic nerves are inflamed, and also you can see there's some inflammation around the edge of the nerve, optic paraneuritis, which is common in MOGAD. Again, in this coronal image, you can see both optic nerves are inflamed. Often in MOGAD, if the vision is fairly good, recovery from optic neuritis can be excellent after steroid treatment. By the way, my name is Brandon Beaber, and I want to give special thanks to Dr. Eowyn Flanagan, an academic neurologist at the Mayo Clinic, who's done a lot of great research on MOGAD and also personally sent me citations to help with this presentation. In addition to optic neuritis, MOGAD can cause transverse myelitis, inflammation of the spine, causing numbness and weakness of the arms and legs, and sometimes bladder problems. On panels A and B, you can see sagittal images like this through the thoracic spine and the area of the chest. The spinal cord should appear dark like this. Here you can see the bones, the vertebrae, the discs in between, and the normal dark spinal cord. These white areas indicate transverse myelitis or inflammation. Sometimes you see shorter segments like this, and sometimes longer sections, as I'll show in a moment, known as longitudinally extensive transverse myelitis. It can occur in any area of the spine, including the very bottom of the spine, known as the conus medullaris. If you look at cross sections, axial images, as in panels C and D, you can see it often involves the center of the spinal cord, and sometimes, as in panel D, exclusively the gray matter, creating the so-called H sign. These images show longitudinally extensive transverse myelitis, a very long lesion, atypical of diseases such as multiple sclerosis, and again the H sign here. And the way the spinal cord is organized, the motor fibers are mostly in the lateral spine, the sensory fibers are mostly in the back of the spine, so you can have a long lesion, but if it's mostly in the center of the spinal cord, you might have fewer neurological problems than you might expect. This is another example of longitudinally extensive transverse myelitis, but if severe, it can cause quite significant neurological problems, such as severe weakness of the arms and legs. Another syndrome associated with MOGAD is ADEM, acute disseminated encephalomyelitis. This is extensive inflammation of the brain and spine, sometimes occurring after a viral infection or vaccination, more common in younger individuals with the disease. For instance, this is a 6-year-old boy with MOGAD and extensive brain lesions. People with this condition are often confused, have fever, in addition to specific neurological problems such as weakness or speech difficulty, though dramatic improvement or even complete resolution of symptoms is definitely possible. There's evidence that people with ADEM who have anti-MOG antibody, if the antibody goes away on subsequent testing, having chronic relapsing disease is less likely, whereas if the antibody is still positive months later, a chronic relapsing condition is more likely. These are some more brain lesions in MOGAD. You can see they're diffuse, fluffy, and fill up the gyri, going right up to the cortex, but sparing the gray matter, very atypical of a condition like multiple multiple sclerosis. However, in rare cases, MOGAD can involve the cortex. These are MRI images of a 10-year-old girl with MOGAD causing seizures. And you see these unusual flare bright images in the cortex at the very surface of the brain, highly unusual. Some people have called this FLAME, standing for flare, which is an MRI sequence, lesions in anti-MOG associated encephalitis with seizures. And this is another example of inflammation at the very cortex and the right temporal lobe in another individual with MOGAD. Very unusual, could easily be misdiagnosed for something else. We can also see focal brain lesions. For instance, this lesion in the right middle cerebellar peduncle can cause tremor, dizziness, imbalance, very similar to what we might see in multiple sclerosis. These bilateral lesions in the thalamus can cause sleepiness, confusion, even narcolepsy, similar to what we might see in anti-aquaporin 4 related neuromyelitis optica. These strange lesions, posterior limb of the internal capsule and midbrain, and these unusual subcortical and juxtacortical lesions. So what is MOG anyway? Well, myelin oligodendrocyte glycoprotein, as pictured here, is a component of myelin, the fatty coating of the nerve fibers that protects the axons and expedites nervous transmission. It's expressed on the surface of oligodendrocytes, the cells in the central nervous system that make myelin, and it's involved in microtubule function. Microtubules are the protein scaffolds of the cell that change and mold the shape of the cell. This slide shows the pathophysiology of MOGAD, where anti-MOG antibodies are created by the immune system for unknown reasons. They bind MOG and recruit other cells which cause injury to the nervous system, causing the symptoms. Scientists have known about MOG for a long time, but anti-MOG was only discovered in 2007, and its clinical significance in this distinct syndrome is only more recently appreciated. Now, be careful interpreting this test as a low positive result. Could be fairly common in the general population, about 1 to 2% of controls. These numbers, 1 to 20 and 1 to 40, refer to titers, in other words, serial dilution of the sample until the signal goes away. So 1 to 20 is a weaker signal than 1 to 40. And these low positive results can be fairly common, so it's not practical to test people, say, with a clear diagnosis of a different condition like multiple sclerosis, because you'll get a lot of false positive results. However, high positive results are much less common in the general population of 1 to 100 titer or greater, and they're more consistent from lab to lab. If you have a low positive result, it could be positive in one lab but negative in another lab, whereas a high positive result is much more convincing. According to one study, the specific epitope of the antibody could be significant. Now, this sort of thing wouldn't be commercially available, but this study found that if anti-MOG does not bind the proline 42 epitope, the risk of having a relapse is 70% higher. So maybe in the future we'll be able to predict who has a relapse with greater efficiency. Next, we move to epidemiology. This disease, MOGAD, is extremely rare, with an incidence of only around 2 to 3 per 1 million, though I suspect that it's going to be increasing as more people are testing and discovering it. There are probably a lot of people walking around undiagnosed. Also, incidence is not the same as prevalence. This is just the rate of new diagnoses per year, but of course this is a chronic condition, and so the rate is much higher, but still on the order of 1 in tens of thousands. Unlike most other autoimmune disease, the risk of men and women is the same, 1 to 1. Compare that to the related disease, anti-aquaporin 4 related neuromyelitis optica, which is 90% women. Not the case for MOGAD, 1 to 1 men to women. Also, it tends to affect younger people. The median age of onset, according to one study, was 24, and some studies show around half of people with the disease have an onset during childhood. Compare that to the average age of onset in multiple sclerosis of 30, and for anti-aquaporin 4 related neuromyelitis optica, average age of onset of 40. And unlike NMO, it is not strongly associated with systemic chronic autoimmune diseases such as lupus and rheumatoid arthritis, although there are reports of association with anti-NMDA encephalitis, and some people have both the anti-aquaporin 4 antibody in addition to anti-MOG. There are formal diagnostic criteria for MOGAD. I present to you a simplified version. You have to have a clinical event typical of MOGAD, such as optic neuritis, transverse myelitis, acute disseminated encephalomyelitis, etc., and the anti-MOG antibody. Otherwise, what are we talking about here? And other diseases that could cause the same symptoms have to be excluded, especially multiple sclerosis, since that's by far the most common chronic autoimmune disease of the central nervous system. For people who have a low anti-MOG antibody, there's the potential for a false positive and misdiagnosis, so there are additional criteria. You need negative anti-aquaporin 4 antibody, else the diagnosis may be neuromyelitis optica, and supportive features on MRI scans such as the ones I showed earlier. A spinal tap may not be that useful for diagnosing MOGAD. The finding that's seen in about 90% of people with multiple sclerosis having more than one oligoclonal band in the cerebrospinal fluid but not in the blood is only seen in 5 to 20% of people with MOGAD. During a MOGAD attack, it's common to have elevation of white blood cells, lymphocytic pleocytosis, and 29% of people with MOGAD have more white blood cells than 50 per microliter. This is a very high amount. Normal is less than 5. During a multiple sclerosis attack, we might see 5 to 15, so greater than 50 is definitely a lot, atypical of multiple sclerosis, but this is only 29%, and between attacks, it can be completely normal in MOGAD. We know a little bit about the prognosis of MOGAD from early observational studies. Only about 50%, perhaps a little more than that, go on to have a relapsing course. Many people, even if they have a single demyelinating event and test positive for the anti-MOG antibody, they actually don't have future attacks. So let's say you have optic neuritis, test positive for the antibodies. Will you go on to have future attacks if you receive no treatment? We really don't know. Studies suggest that if the first attack is polyphasic, meaning you get worse, then get better, and then get worse again, that predicts greater likelihood of having relapsing disease, in other words, future attacks. There's this phenomenon with MOGAD of steroid withdrawal causing recurrence of symptoms. So you're treated with steroids, your symptoms get better, and then you try to come off the steroids and your symptoms come back again. We also know that if you have high cerebrospinal fluid protein, that increases the risk of a relapsing course, though the association is fairly weak, so it's not a great diagnostic test. Interestingly, in MOGAD, MRI lesions of the brain or spine can actually go away even if you had an attack of that region. So you can have an MRI scan of the brain after ADEM that is completely normal, or an MRI of the spine after transverse myelitis that is completely normal, particularly if the symptoms improve. Now, the most common symptom is optic neuritis, and often the recovery is good, especially compared to people who test positive for the anti-aquaporin 4 antibody. Based on some observational studies, only 6 to 14% have legal blindness after optic neuritis. In other words, a visual acuity of 2200 or worse. And so most people have a fairly good recovery, and I've had patients recover to 20/20 vision, although I've also had patients who have had numerous attacks and have accumulated some significant visual loss, although don't go too much based on my own clinical experiences, because I believe I have less than 10 patients with MOGAD in my entire career, and many of them weren't diagnosed with MOGAD early on because antibody testing wasn't even available. Just like with multiple sclerosis, the risk of attacks in MOGAD goes down dramatically during pregnancy, as shown in this study, but goes back up to normal after delivery of the baby. Let's now move to treatment of MOGAD. Now, there are no randomized controlled trials, so this is all based on anecdote, expert opinion, and observational studies. And we'll start with treatment of acute attacks, so someone that has optic neuritis and transverse myelitis and has active symptoms right now. The standard treatment is high doses of steroids, such as methylprednisolone or solumedrol, 1,000 milligrams daily for 3 to 5 days, and there's an alternative treatment of oral prednisone. The dose is 1,250 milligrams, again, daily for 3 to 5 days. And this is usually given with an acid blocker such as Prilosec because it can upset the stomach. Now, many people with MOGAD have this steroid rebound phenomenon, so they may need oral prednisone at a lower dose, sometimes for a prolonged period of time. And I actually have one patient where nothing seemed to work with them. They needed to take prednisone for a very long period of time, which isn't a desirable treatment because it can cause weight gain and other side effects. Another option for an attack is IVIG, or intravenous immunoglobulin. These are artificial recombinant immunoglobulins that block the effect of your natural immunoglobulin production. It has side effects such as headaches, allergic reactions, and in rare cases, kidney disease and clotting events such as stroke and heart attack, but fairly rare in a young, healthy person. Another option is plasma exchange or plasmapheresis. This is a dialysis-like procedure that removes abnormal antibodies, complement, and cytokines. Now we'll move to long-term preventatives, medicines to prevent a future attack of MOGAD. One option is prednisone, though as I said, it's not desirable on a long-term basis because of the side effect profile. IVIG, just like it's used in acute attacks, can be given routinely on a regular basis. And then there's some immunosuppressant medications, a few pills, mycophenolate mofetil or Cellcept, azathioprine or Imuran. These are twice-a-day pills, and they're sort of weaker immunosuppressants. They have side effects like gastrointestinal upset. They can affect the liver and cause infections. Another option is medications which take away the B lymphocytes, the cells that make antibodies, including anti-MOG. The most commonly used one is probably rituximab. You can see the trade names. These medications have side effects such as infusion reactions and suppression of the immune system, causing infections, and other drugs that work in the same way, Ocrevus, ofatumumab, or Arzerra, Kesimpta, or hey, why not Gazyva, Briumvi, they could work just as well. And more recently, it's been found that medications that work on interleukin-6, a cytokine involved in immune cell signaling, such as Actemra tocilizumab, could also work. So which drug is the best? Well, we don't know, but I'll show you those 6 observational studies. Keep in mind, these are not randomized trials. It's not random who gets what treatment. There could be some biases, so don't take this as definitive, but it may give us a rough idea. So this study had 88 people with MOGAD, and they had relapsing disease, meaning at least 2 attacks and the antibody. And we're going to look at ARR, which is annualized relapse rate, relapses per person per year. For instance, if the study is for 2 years and someone has 1 relapse, that's an ARR of 0.5. So people taking IVIG had an annualized relapse rate of 0.13. This is excellent, about 1 attack per 8 years on average. For B-cell depleters such as rituximab, it was much higher, ARR of 0.51, and this is a surprise to me, not so great. For mycophenolate mofetil Cellcept, it was in between ARR of 0.32. This graph summarizes the results, and they tried to look at it in different ways. They looked at, coded in dark blue, optimal dosing, people who got an ideal dose. They looked at monotherapy, people receiving only that drug and no other immunotherapy, but it didn't really matter. You can see people pre-treatment without medication, the annualized relapse was around one attack per year, and IVIG clearly did the best. This second study looked at 124 people with MOGAD, and these are people who just had a single attack, not already relapsing disease like the prior study. Median follow-up of around 4 years, pretty good, and 40.3% remained monophasic, meaning they did not have a subsequent attack, and the remaining 60% had at least 1 subsequent attack. So if you have a single event like optic neuritis and you test positive for the antibody, do you really need long-term immunosuppressive treatment? We just don't know. Now, they did find that starting therapy was linked to a lower risk of having a relapsing course, and they looked at the hazard ratio, which is the risk relative to not taking immunotherapy. So for IVIG, the hazard ratio was 0.1, which is excellent, 90% reduction. For rituximab, also very good, 0.21, a 79% reduction. And for mycophenolate mofetil or CellCept, it was 0.27, a 73% reduction. The drugs look fairly effective. This study looked at 70 people with MOGAD, and they noted prior to treatment, the median annualized relapse rate was pretty high, 1.6, so almost 2 attacks per year. With mycophenolate mofetil, the people in the study had an annualized relapse rate of 0.67, not that good, but lower than baseline. With rituximab, it was 0.59, again, not that good in my opinion. With Imuran, it was 0.2, that's pretty good. With IVIG, it was 0, although only 10 people got IVIG, but definitely IVIG is looking favorable. Now, some people in the study were initially erroneously diagnosed with multiple sclerosis and treated with platform multiple sclerosis disease modifying therapies. I presume they're referring to gluteramine acetate and beta interferons, and they were not effective. All 9 had attacks with an annualized relapse rate of 1.5. What about those interleukin-6 drugs I mentioned? Well, this is an observational study on Actemra tocilizumab. So these drugs work in anti-aquaporin 4 related disease, so it makes sense they could work in MOGAD. And this had 57 people with MOGAD, median exposure 23.8 months, about 2 years, and their baseline median annualized relapse rate was high, 1.75, but while on Actemra, they did well, and in fact 79% were relapse-free, and MRI activity also decreased. And this is data from 14 of the individuals in the study, and this line represents the start of Actemra treatment, and you can see they had far more attacks prior to treatment than afterwards. This is an observational study from France and Spain, 125 people with MOGAD. If you looked at people who were treated with something versus untreated, the treated people had 59% fewer attacks overall, and these are the attack rates for specific medications. For Imuran, the annualized relapse rate went from 1.05 to 0.43. For CellCept, 1.2 to 0.23, a dramatic reduction. And for rituximab, 1.08 to 0.43. Now keep in mind there's a regression to the mean effect where people tend to have more attacks right before diagnosis and treatment because that's what led to them getting diagnosed and treated in the first place. MS platform drugs were not effective, no statistically significant reduction in attacks. And these are, of course, people who were misdiagnosed with multiple sclerosis. This is an observational study just on IVIG, data from 9 different countries. They had 59 participants receiving IVIG, and 52 out of 59 were still treated with it by the end of the observation period, and those 52 individuals had a median treatment duration of 1.7 years. Their pre-treatment relapse rate was an annualized relapse rate of 1.4, so more than 1 attack per year, but during the study they did fairly well. 39 out of 59, which works out to 66%, were free of relapses, though 2 people stopped treatment due to side effects. So to put it all together, preliminarily IVIG looks good, Actemra, IL-6 agents look good, certainly azathioprine and CellCept are options. Rituximab is probably effective, but maybe not as much so as I would have imagined. But we'll get more data because there are ongoing randomized trials. This is a phase 3 randomized trial of satralizumab, Enspryng, FDA approved to treat anti-aquaporin 4 related neuromyelitis optica. This is an IL-6 blocking drug, just like Actemra I showed you earlier. There's another trial on Rystiggo. This drug blocks immunoglobulin recycling, already used to treat myasthenia gravis. Can it work for another antibody-mediated disease? So if you have MOGAD, I'd be interested to know. Post in the comments below, what were your symptoms? How did you find out about it? Were you misdiagnosed maybe with multiple sclerosis for several years? Have you tried any of the medications I mentioned, and what were your results? And did you have side effects? Did it prevent subsequent attacks? And would you be willing to enter one of these phase 3 randomized trials? And as an Easter egg, while I was filming this video, something happened. I had to stop filming, and I filmed the rest on a subsequent day. If you can figure out the exact moment that happened, it should be obvious. Post in the comments below.